Yeah, so I'm going to present two papers together. Actually, this is very interesting study. What they did first, they have published one paper in Nature Medicine in 2024, where they have studied the intrathecal bivalent CAR T cells, where they've targeted EGFR and IL13. Both are overexpressed in glioblastoma. And then in this first trial, they just published the interim results which they found over a period of time. Then after that, they published another paper where they changed. Actually, in this study, in this clinical trial, they have done lots of changes. So far, 15 amendments has been done in this trial. So then later in then they did intracerebroventricular delivery of bivalent card. So here, because I'm not from medical background, so this is really confusing for me that what is difference between these two. I know these are the local deliveries at the tumor site. Am I right?
So intrathecal is like giving via lumbar puncture,
Mm-hmm.
and intracerebroventricular is through a Ommaya reservoir.
So, but at
It is
the
post surgery. Means intracerebroventricular is after inserting a
some
Ommaya reservoir. Yes,
yes, the
but
brain.
delivery of site is CSF only.
Yeah. So directly into the tumor site, I mean to say.
Mm,
No.
in CSF actually.
Yes. So then in the that second paper which they have which they have published, this is related to intracerebroventricular delivery, and this is complete phase one trial. So as we know that recurrent glioblastoma is an aggressive brain cancer form where the overall survival is less than a year, and the available therapies are surgical resection, then radiotherapy, and then sorry, and then chemotherapies. Currently, that lomustine, bevacizumab, and irradiations are the currently therapies for recurrent glioblastoma. So, as we know, CAR T therapy, which is showing very good results in hematological malignancies, but in solid tumor, the results are not that good because of tumor heterogeneity, immunosuppressive tumor environment, and there is blood-brain barrier. So in this study, they've tested bivalent, or we can say bicystonic CAR T cells, where they've targeted two genes, EGFR and interleukin 13 receptor alpha 2. Both are overexpressed in case of RGBM. But again, in this, there is a catch in this that for EGFR, they have mentioned that what should be the how do they qualify for EGFR overexpression. So there are later slides I will show that what are these parameters, how they've selected EGFR overexpression in these cats. Then the therapy they have delivered is ICV. So here I'll show you how these CAR T are difficult in solid tumor. First is because difficult to cross the BBB, that blood-brain barrier. Then second is immunosuppressive environment. Just a moment. Immunosuppressive microenvironment. In immunosuppressive microenvironment, we can see that there are Treg cells, there is immunosuppressive cytokines which suppress the activity of T cells. There are other tumor-associated macrophages. Hello.
Yes, ma'am, you are audible. You can continue.
Yeah. So these tumor suppressive microenvironment also affect the efficacy of CAR T in solid tumor. Other is checkpoint inhibitors. Here, this PD-1 and PD-L1 gene or expression, they also suppress, they cause T cells exhaustion. So the T cells, after some time, their expression diminishes. Then hypoxic tumor environment is also there. So in hypoxic tumor environment, because of the dense this thing, there is deposition of collagen and then other proteins that because of that, the infiltration of these CAR T cells is difficult in this microenvironment. And then there is this alpha expression also increases, which increase the expression of VEGF and faulty that blood vessels are there, and because of that also these T cells don't reach to the target. Then again we know that there is T cell exhaustion, and then tumor heterogeneity is there because of that antigen escape is there, and then after that sometime that there is low expression of these antigens. So these are the limitations of CAR T cells in solid tumors. So in first paper, which they've published a year back, they've published some interim results. So in that, they've just did a study in 6 patients. And in this, they found out that after the infusion of T cells, within 24 to 48 hours, there was reduction in tumor size. And but the limitations of this study was that it could not fit the this objective radiographic response, which is defined by the in neuro-oncology criteria. Safety profile also they have checked, and then in that also it is like there was early onset of neurotoxicity, CNS, which is associated with CAR-T. And these, they mentioned that these adverse effects were managed by giving some interleukin therapy. And then, but ultimately they found out that these bispecific CAR-T, they are functional, and because of that they check the complete profile of cytokines which is released. So they found out that they can go ahead with these CAR-T, bispecific CAR-Ts. Then that's again in next clinical trial, this completely clinical trial. So this was their study design. This was the first in human phase 1 single centric open label trial, where they have used 18 patients only. And then main this thing requirement is there that they should be IDH wild type. There should not be IDH mutations in these patients. Should be EGFR amplified, and then post radiotherapy with progressive multifocal disease. This was the requirement for the therapy. Then there is ICV infusion of this bispecific CAR-T by Omenya reservoir, and this was the dose escalation. So they've used 3 doses. One is 10 to the power 7 cells, then 2.5, and then 5 into 10 to the power 7 cells. Again, they have done some amendments in this trial. They found out that though they have mentioned here 3 doses up to 5, but they found out this 2.5 was very toxic, so they did not use this label 3. So they did their study by using only first and 2 dose levels. So this was the endpoints. Primary endpoint was to find that limited dose limited toxicity, what is the maximum tolerated dose, and then what is should be the dose for second phase trial. That means recommendation dose for expansion. The secondary objective was for the duration of the, what is the progression-free survival, what is the duration of the response, and overall survival. This is how they have selected these 18 patients. So first they've checked the EGFR amplifications, what is the percentage, and how they are eligible for this study. And then after that get apheresis consent. Then they've checked what is the disease profile, like disease recurrence and other screenings. And then after confirmation of the eligibility, they start manufacturing. And then dose allocation they have done. So because as I have mentioned in the previous slide, they did not go for the third dose. Rather than they selected a -1 dose level, where that dose is less than the that which they have described there. So there they have used only 5 million cells. And after then that pre-infusion safety visit, day 14, and then CAR-T injection. So first they've recruited 56 patients. In 56 patients, this clinically they were ineligible for leukapheresis. Then one withdraw from the study. Then they did leukapheresis in 50 patients. Out of those also. So ultimately, they've selected only 18 patients which were fit for this study. So in that inclusion criteria, so as I mentioned, that main inclusion criteria, it should be IDH wild type. Because according to that following RDH, this because if there is mutation in that in this gene also, so then I mean to say reference would be very much different. So this should be the main inclusion criteria, that patient should be EGFR positive, but IDH there should not be any mutation in this dehydrogenase gene. Then the record for previous radiotherapy should be there, and then here the tumor tissue positive for wild type EGFR, here also they have mentioned different criteria. Accordingly, they have chosen that how this is EGFR amplified mutation. But again, that limitation of this study is the presence of, because they have selected bispecific CAR-T. That means they are targeting both two targets, EGFR and IL13, which is being seen overexpressed in multiple GBMs. But they did not they did not mention any criteria for IL13 expression, because up to now there is no valid assay which can check whether this is overexpressed or not non-overexpressed. So they did not check they did not mention here any criteria for IL-13. So these are the other normal inclusion criteria. So I'm not going into all this because you must be knowing more than me in these cases. Then this is exclusion criteria. This should not be any hepatitis B or hepatitis C, any uncontrolled infection or any cardiovascular disease. And another exclusion criteria which they have mentioned, that tumors primarily localized to the brain stem or spinal cord. This, I'm sorry, I could not understand why they kept this in exclusion criteria. So if anyone knows or understand, please let me know.
वो इसके लिए क्या प्रेरणा था, क्योंकि ब्रेन स्टेम और स्पाइनल कॉर्ड के ट्यूमर होते हैं ना, उनका
Yes, sir.
बायोलॉजी अलग होता है.
Okay,
मोस्ट ऑफ द टाइम H3K27 म्यूटेटेड रहते हैं,
Okay.
एंड इन दोस सिचुएशन B7H3 और GD2 ज्यादा अच्छा काम करने का चांसेस था, इसीलिए.
ओके ओके, ये मुझे नहीं समझ रहा था. ओके सर.
Dr.
So
Vijay,
then,
sorry, this is Harsha here. Is there another possibility that the edema there would be more harmful in nature?
Harsha ji, that is a possibility, and
Okay.
I would have agreed with you, but issue का झाला है ना, the issue is कि B7H3 and GD2 which are specifically tried now in brainstem gliomas, and we know now
Okay.
that we know that these issues which would cause edema or could cause instant death were not seen in the trial.
Fantastic. Thank you. That's helpful.
so this is because of the localization of the tumor, they have not selected it.
नहीं, this is with the, there are both reasons. जो हर्षा जी ने बोला वो भी सही है. As a
Okay, sir.
neuro-oncologist, you're always worried about taking patients in brainstem and spinal cord. Biology is bad and they have a poor prognosis. Okay, but now we know that when this was planned, they probably did not know. Now with the other results coming of brainchild study and GD2 study, we know that it is not so.
Okay, I understand, sir. So then there is other limitation is that they should not receive any bevacizumab antibodies within 3 months before the clinical trial. So this was also why I could not understand.
This is why Dr. Harsha was telling you. Bevacizumab is commonly used in patients who have a lot of edema.
Okay,
And
so how it will hinder?
No, it won't hinder. If you give bevacizumab with CAR-T, it will actually increase its penetrability. But the problem is, if you are taking patients who are on bevacizumab, which means there is a high risk of bleeding, and also there is a high risk of that once the bevacizumab stops, the edema might recur.
Okay, understand.
And second, what they did with this criteria is they selected actually very good patients.
Okay, yeah. Because there are many loopholes in this study, which I will mention later.
Yes, good.
Yeah. So that's pregnant nursing women and then any kind of allergy or hypersensitivity. So this is how these are the this patient characteristics. So in this 3+3 model they've used, and then in out of these 18 patients, this is how they've selected. So this is the result outcome. So in maximum, we can see in patient more than 10 patients, there is grade 3. No one has that grade 4. Yes, there is grade 4.
The issue will be if you are talking about grade 4 side effect, there is only one grade 4 side effect, that is lympho count decrease. Now, if we are talking about grade 4 glioma, all these patients will be considered grade 4 only, Prerna. Because according to today's WHO classification, if the patient is IDH negative, these all patients are classified as molecular glioblastoma.
Okay, that's why they have not taken that IDH.
The IDH has a good biology. They do well even with IDH inhibitors.
Okay. So this is how they've selected that this patient. So almost 80% of them they were facing grade 3 toxicity. So these are the complete profile of the toxicities. They've mentioned how many patients, what they were their side effects. So as you mentioned, like 100%, that CRS is 100%. Shall I move forward with another slide?
Yes, please go ahead.
Okay. So this is the result. They are showing that the number of CAR-T inside the CSF they have checked, CSF and in blood, in both they have checked. So here we can see that maximum of the date, and there is the maximum, and in dose level 2 we can say, which is 2.5. 2.5. So here we can see the presence of this is in microgram of this thing, the CAR-T copy. And this is after this is time frame. So we can see in after that it is reduced both in peripheral blood and both in CSF. Here also we can see that this is the dose level 3, which is showing the best persistence inside both CSF and in the blood. Again, I'm sorry, this is not very much clear. And then, but we can see actually in this, only in one patient, which was facing severe toxicity, but the tumor reduction was very good. And after they managed that toxicity, that only one patient, he survived and he was doing very good after the treatment. So again, at the molecular level, that limitations where I will show you here, though this is bispecific CAR-T, they have used two antigens, EGFR and IL13. But here we can see the percentage of EGFR is like in somewhere is more than 50% also. But the percentage of IL13 CAR-T, expression inside the CSF and in blood, we can see that percentage of this IL13 is very less. So that is the limitation. I think they should standardize their production, their manufacturing of CAR-T, where there should be expression of both these genes, IL13 as well as EGFR. At least there should be the equal expression. But their expression we can see here in it. So might be that reason from where they have selected this IL13. That SCFV, they should change the protein, or that fragment they should change, so that expression level should change, be equal to the EGFR. Here they have that doses which is fall under the target dose, but that does not fall. These in case of IL13, that expression level is very low. So this is the study outcome.
So just give me a minute. So Kritika, Neelam, Namit.
Yes, sir.
SCFW fragment is the fragment which is used by the CAR-T to identify the antigen. So if that fragment percentage is less, then the CAR-T won't identify the antigen. And if it does not identify the antigen, it is not going to work. Okay.
Yes.
So that is the importance of SCFW fragment.
So in this study, we don't understand. So they need to modify. I think later they have mentioned they will modify that this protein fragment level here because the expression is very less.
Okay.
So the study outcome is that they have selected this 2.5, that maximum tolerated dose is to be 2.5 into 10 to the power 7, though previously they mentioned it should be 5 point. Actually, in case of like chemotherapies and also like we understand that which is the maximum showing the maximum toxicity is the best dose. But in immunotherapy, it is not like that which is showing maximum toxicity is the dose to be selected because it is associated with various that effect. So we cannot select that maximum which is showing maximum toxicity. So that is why I think they have selected, they did not touch 5 into 10 to the power 5 cells. So out of these 18 patients, 10 patients experienced grade 3 neurotoxicity and no one had this 4 to 5 neurotoxicity. Out of 13 patients, that means 62%, they have measurable disease at the time of CAR-T infusion. There was tumor regression in those cases with confirmed partial response, and then which met to this neuro-oncology criteria. This is, I was talking, one patient with ongoing durable stable disease lasting over 16 months. Median progression-free survival was 1.9 months, and then median overall survival did not reach at the cutoff time because they published this paper before that. So here they confirm that this indicate that this intracerebroventricular delivery of this bivalent CAR-T is feasible and appears to be safe. And then these CAR-T are bioactive. That means they are releasing cytokines, and then they can show the anti-tumor effect in RGP. So the significance of the study is first in human trial bivalent CAR-T targeting 2 antigens there. ICV delivery proved feasible and enhanced T-cell access to the CNS tumors, which is a critical advancement in solid CAR-T. And the preliminary efficacy of 62% tumor regression is being shown here in dual target CAR-T. But the limitations here are that sample size is very small. This just only 18, and that too very good patient they have checked. So we don't know that whether this is really good criteria or not. And then the transient response, because there is rapid tumor regression after some time. Even in some patient in their supplementary data, they have mentioned that after some time, then again tumor has started in multiple of the patients. This neurotoxicity was very high, and then that heterogeneity I always discuss that because expression was very low, and then lack of long-term data. So that is the limitations of this study. But I would suggest, sir, smartly what they have done then, because this impact factor of this nature medicine is very high. From this study, they have published 2 papers smartly with just showing this interim results and then the other results, not even in phase 2 or phase 3.